Hi, my name is Martha Noel. I am a reproductive endocrinologist and infertility specialist at RMA of Northern California. And it is something that's really, PCOS is something that's really commonly given to people as a diagnosis, often without like the sort of full diagnostic workup behind it. So I think it's really important to talk about specifically how you diagnose it and what it is. So it's a really common reproductive disorder. It affects, depending on how you define it, between like 5 to 8% of reproductive age women. So the kind of classic symptoms that are associated with PCOS are irregular cycles. So fewer cycles per year, not more cycles per year. Sometimes those are like regular periods, they last for a week or so and then they go away. For some people with PCOS, they won't get a period for like several months and then they'll have like a month of bleeding and then it'll stop and then they won't get a period for several months again. So it's a little bit about the frequency of the periods that you have, but they may not be like totally normal periods when you get them. And the reason for that is that people with PCOS don't ovulate. They don't release an egg regularly. So sometimes that leads to irregular bleeding that can last for longer than a typical period would. So that's kind of one part of the, one common symptom that people have. The other is kind of how this high level of testosterone manifests in the skin. These are not male levels of testosterone. These are testosterone levels that are high for a reproductive age female. And there's kind of two ways that this can manifest. It can either manifest as in a blood test for testosterone, the number is high, or a little less commonly, it manifests as normal levels of testosterone in the bloodstream, but sort of exaggerated physical response to testosterone, which is typically really severe acne, excess hair growth kind of in a male pattern distribution. So like the temples, the jawline, sort of above the upper lip, chest, stomach, and back, or male pattern hair loss. So hair loss from like the temples and the front of your hairline or like the central part of your scalp in the back. And then the third kind of big one is weight gain. PCOS, part of what underlies PCOS is something called insulin resistance, which means that your body doesn't process sugar or glucose as efficiently as somebody without PCOS. And when that happens, glucose levels in the bloodstream build up, and that translates often into kind of fat deposition. And so increased weight gain. It's kind of easier for someone with PCOS to gain weight and a little harder for them to lose weight because of that. PCOS or Polycystic Ovary Syndrome is like a little bit of a misnomer. People often think it means you have a lot of big cysts all over your ovaries, but you don't. It means you have a higher than average underlying egg count for your age. And so there are criteria on ultrasound that you can use to see how many eggs a person has in their ovaries and then how big the ovaries look on ultrasound. Usually people with PCOS have larger ovaries than normal. There are people who have what's called lean PCOS. So this is sort of like a different type of PCOS. People sometimes think that the underlying physiology of it is a little bit different. Oftentimes people with lean PCOS don't have a lot of the high testosterone symptoms that people with kind of classic PCOS have. They generally are, they still have the kind of irregular cycles. They may have a high underlying egg count, but they don't have a lot of the testosterone mediated symptoms and they don't have a lot of the weight gain. One thing that I hear a lot from my patients about this is that they feel like they are not doing something right. Like they are working out, they are eating well, and they are unable to lose weight that they have gained, or they're still struggling to even maintain their body weight. And I think it's really important for people to know that a lot of what underlies PCOS is genetic. So the receptor in your body that is responsible for responding to insulin doesn't work the same way in people with PCOS as it does in people without PCOS, and that's a genetic variant. And so it's not like you're doing something wrong or you should be doing something that you're not. It's that the way that your body works is different, and it makes it harder to process insulin and process glucose properly. So the way that I think about insulin and glucose is, you eat a meal that like essentially results in increased levels of glucose or sugar in your bloodstream. Insulin gets released from your body to help to get the glucose out of your bloodstream. When it doesn't do that well, that glucose really gets turned into fat cells. And so if you're not able to get the glucose out of your bloodstream in the same way or as efficiently as somebody else who doesn't have PCOS, that's going to result in increased buildup of fat. And that makes it easier to gain, harder to lose that weight. So, I think there's not a magic bullet for this for people with PCOS. And really, additionally, like we know that, ultimately weight and BMI, it's actually not a great measure of your physical health, right? But some of the same rules that apply to anybody who's trying to live a healthier lifestyle apply to people with PCOS. So from a dietary standpoint, for example, avoiding things with high levels of simple sugars in them. So simple carbohydrates, that's, white bread, flour tortillas, white rice, that kind of thing. Your body is going to be more sensitive to those than somebody who doesn't have PCOS. And you really try to limit that type of simple carb. Sugars, sodas, sweets, desserts, that kind of thing. It doesn't mean you have to give it up altogether, but just you try and reduce that in your diet as much as you can and replace it with things like whole grains, fruits and vegetables, beans and other things like that, chicken, fish for proteins. Just like anybody would who's trying to control their weight through diet alone. But it's just more important for people with PCOS because they are more sensitive to these things. Exercise is particularly important. Really what we've seen, and people see this in other diseases like diabetes that are associated with insulin resistance, is that exercise that builds muscle mass is really important because your muscle processes a lot of the glucose that circulates in your body. So the more muscle you have, even if your insulin receptor isn't working as well, the more muscle you have, the more glucose you'll be able to process. So weightlifting, things that can build your muscle can be really helpful. It's not just about doing aerobic exercise. From a medication standpoint, there are medications that people use to try and help with insulin resistance. The most commonly used and the one that's been used for the longest is something called Metformin, which is an insulin sensitizer. So it helps the insulin, helps your insulin process the glucose better. Generally, I use Metformin for women with PCOS whose bodies have started to show signs of really kind of perpetually elevated levels of glucose in their body. So if you have insulin resistance, your body tries to compensate for that by making more and more and more insulin. Over time, it's not able to do that anymore. It kind of burns out a little bit. And then you start to see people developing pre-diabetes and diabetes. Metformin really we use for people with PCOS who have started to show signs of pre-diabetes in their blood testing rather than just across the board for everybody with PCOS. It's not always the easiest drug to take, Metformin. It is generally the most common side effects are nausea, diarrhea, kind of GI upset. The kind of best way to try and mitigate those side effects is to go up on your dose of Metformin really slowly when you start it. So you start out off at a really low dose. Over a period of 1 to 2 weeks, you kind of increase that by one level, increase again, so that by the time you're kind of at your goal dose for Metformin, you've been on it for 6 to 8 weeks. That kind of allows your body to tolerate it a little bit better. If you reach a level where you start to develop side effects, you can kind of drop back down to the dose you were on before and stay at that dose a little longer before you try and increase again. But a lot of people talk about the GI, a lot of the reasons why people stop Metformin is the sort of GI side effects that they have. there's a big because there's a big genetic influence to PCOS. There's a big heritable component to it. So what that means is that if you have PCOS, there's a 50% chance that your mother had PCOS, that your sister would have PCOS, or that your daughter would have PCOS. So that really speaks to like the importance and the impact of genes in this. It doesn't mean that the environment doesn't play a role either. We sort of live in a world in which most of us are not eating a very healthy diet all the time, or it takes a lot of work to eat a healthy diet and not eat processed foods and things like that. So I think kind of just the way in which, particularly in the US, like the way in which we eat underlies a lot of the initial signs of PCOS. We're probably seeing it in people a little earlier than before because people just aren't eating well, even in childhood and as like young teens. So there's a component of that too, but really the main underlying cause is a genetic cause. It really goes back to that idea of the genetic insulin resistance, right? So that's something that, because it's genetic, is in you from birth. So even in childhood, you're not processing glucose as well as somebody else might be. But it doesn't really manifest, or you might not see the consequences of it for PCOS specifically until you get into your teens, because that's when people go through puberty and they start to have periods. And so that's often when PCOS is first diagnosed, is in teenagers. The caveat to that, though, is that a lot of teenagers have irregular periods normally and have acne. And so I see a lot of people who were told as teenagers that they had PCOS because of those two things, and they weren't ever really formally diagnosed. And so, if you carry a diagnosis of PCOS that someone gave you when you were 16 and they told you, oh, go on a birth control pill, that's all you need to do for this. As you get into your 20s, like reassess that, and you can do that by seeing a fertility specialist. You can do that by talking to your gynecologist. PCOS is like a pretty complex disorder, and it's a complex diagnosis to make. And reproductive endocrinologists have a lot of training in it. So I think sometimes it's best to see somebody like me, or, who has a lot of experience with it. But don't just take that as this is the diagnosis that I've had since I was 16. And it's, that's just what it is. It doesn't mean that you really have it. You really need to assess it best once you're out of that like period of time where a lot of these symptoms are common in everybody. Birth control pills are like one of the primary ways that we treat PCOS. And I'm happy to talk about that more. They treat it they treat a lot of the different aspects of it. I think, the birth control pill kind of masks things. It masks PCOS. So if you were put on the birth control pill at 16 for whatever reason, and you come off it when you're 30 and you find that you're not having regular cycles, and then you're told you have PCOS, it's not because you were on the birth control pill. You've had it all along. It's just the birth control pill was hiding some of those symptoms. And the way that it does that is it regulates your periods so that you have a bleed every month. You're not ovulating every month. That's how a birth control pill works. It keeps you from ovulating, but it will make you have a bleed. So you don't know that that you naturally would have irregular cycles. And the birth control pill binds up testosterone in your bloodstream so that it's less available to act on the skin. So that's why it's effective as a treatment for the skin symptoms of PCOS, is because there's less testosterone there when you're on the birth control pill. So a lot of people have, their skin looks great on the birth control pill, and then they come off it and they start to get a lot of acne. And so that's really more just the pill is helping with that. And now you're seeing kind of what your baseline would be off of the pill. One of the interesting things about PCOS, kind of this relationship between insulin resistance and irregular cycles. So they kind of work in this feedback loop with each other. So the more insulin resistant you are, the more irregular your cycles tend to be. Prior studies have shown that people with PCOS who lose like 10% of their body weight if they had irregular periods before. Once they've lost that weight, half of them will start to have regular cycles again. So weight loss is actually an effective way to treat like that component of PCOS. And primarily what that impacts is fertility, like your ability to get pregnant. If you're not getting regular periods and not ovulating every month, you can't get pregnant. And so weight loss is a good effective treatment for people with PCOS who have irregular cycles who are trying to conceive, because half of them will start to regulate their periods again. I'm sure that Ozempic and Wegovy and those medications, because they lead to weight loss, will have the same effect. But if you have PCOS and you're trying to focus on the weight loss, I'm sure that those will be beneficial. I have no doubt that there are people studying them for that kind of purpose right now. So I see a lot of people who have PCOS who have been told at some point in their lives that they are not going to be able to get pregnant. And it's not true. It is a little hard. Sometimes people with PCOS who do have irregular periods need a little help to get pregnant. And we can talk about that. But once you are ovulating regularly, somebody with PCOS has exactly the same chance of getting pregnant as somebody without PCOS. So the main fertility issues that underlie PCOS are just lack of ovulation. You're not releasing an egg every month. If there's no egg there, you can't get pregnant. Even if you have, let's say you have periods once every 2 months. So you ovulate an egg once every 2 months. That means instead of 12 chances to get pregnant a year, you only have 6. And it also makes it really hard to time when you're ovulating. You can't figure it out because your periods are all over the place. And so those two things combined, like less opportunities to get pregnant plus having a hard time timing intercourse, makes it more challenging for people with PCOS to get pregnant. There are oral medications that have been studied for a long time that can be used to help somebody with PCOS ovulate. 80% of people with PCOS, when they go on these medications, will ovulate in response to them. And that's a really effective way to treat somebody with PCOS who's trying to get pregnant. And once they're ovulatory, they get pregnant at the exact same rate. There's a lot of stuff published about this. I see a lot of patients who are on myoinositol and other sort of like antioxidants. There's this idea that people with PCOS have poorer egg quality, like the quality of their eggs is not as good as people without PCOS. But really, that isn't true either, or else those people wouldn't get pregnant once they ovulate at the same rate as people without PCOS. Poor egg quality would mean you aren't as likely to get pregnant when you ovulate. And that's not the case. So, I'm a little hesitant to say like there are these natural remedies that you should be trying, because in reality, I think a lot of times working on these things is best done in conjunction with somebody who can help prescribe some of these like ovulation induction medications. Those are really the most effective things if you have PCOS and you're trying to get pregnant. So my advice for people who either have a new diagnosis of PCOS or who are concerned that they might have PCOS, number one is talk to your gynecologist so that you can, make sure you're getting an accurate diagnosis. Number two is if you are in an area where there are centers that do a multidisciplinary approach to treating PCOS, look for them because they exist. Weight loss is a really important part of this, and it can be a really frustrating part of it for people with PCOS. But the earlier you can start to try and adjust your dietary habits, the better. And really to talk about it simply in the terms of weight loss is not really fair. It's really more about improving your metabolic health. And you can do that without actually changing the number that's on the scale, through changing how you eat and also changing the type of exercise you're doing and like your body composition. So I think it's really helpful for people with PCOS to see a dietitian and get like a concrete sort of plan for meals. There's a higher incidence of anxiety and depression in women with PCOS. And so having like a good psychological support there is also really helpful. And then having a reproductive endocrinologist, one, to like make it a accurate diagnosis and exclude some of these things that are mimickers of PCOS but are not. That's an important part of it too. And then I think really like trying to look at this by saying, hey, this isn't something, I think a lot of people blame themselves and saying like, this isn't something that I'm doing wrong. This is something that's in my genetics that I have to deal with, and figuring out, going into all these people and figuring out these ways to deal with that in the best way possible. Don't put the blame on yourself. It's not that you're doing something wrong.